Welcome to the deep dive. Today we're tackling a really distinctive and potentially pretty serious heart rhythm, Torsades de Pointes.
That's right. The name itself, twisting of the points,
Yeah.
it really gives you a clue.
Yeah, you can almost picture it, can't you? That ECG tracing, the peaks just sort of dancing around the baseline.
Exactly. It's this wild twisting pattern of the QRS complexes. And it's not just visually interesting, it's a major warning sign.
Because it's almost always linked to what? A prolonged QT interval.
Almost always, yes. Think of that QT interval as the heart muscle resetting itself, getting ready for the next beat.
Okay.
If that reset, that repolarization takes too long, it creates this electrically unstable situation.
And that's dangerous because
Because it can spiral into ventricular fibrillation, which is chaotic and ineffective, and potentially lead to sudden cardiac death.
wow, even in people with otherwise healthy hearts.
Even then, yes.
Yeah.
It's quite serious.
And these episodes, they might be short, right? Stop on their own.
They often are brief, yes, and self-terminating. But the danger is recurrence. If you don't find and fix the underlying cause, it can happen again.
So that's our goal for this deep dive then, to really break down Torsades de Pointes, what it is, why it happens, and, the key things you need to remember.
Let's do it. So let's really nail down that definition.
Okay.
Torsades de Pointes, TDP. It's a specific type of polymorphic ventricular tachycardia.
Polymorphic meaning the shape keeps changing.
Exactly. The QRS complexes vary beat to beat, but in TDP, they vary in that characteristic twisting or undulating pattern around the baseline, and crucially, associated with that prolonged QT interval on the ECG.
So the twisting ECG, the long QT, those are the immediate red flags you're looking for. Why is that combination so risky, fundamentally?
Well, that prolonged QT, as we said, means the heart's electrical system isn't resetting properly. Repolarization is delayed.
The electrical recharge is slow.
Precisely. And that delay makes the heart muscle cells vulnerable. They can trigger abnormal beats, which can then degenerate into ventricular fibrillation.
Which is life-threatening.
Absolutely. VFib means the heart isn't pumping effectively at all. That can lead to sudden cardiac death very quickly if not treated.
So even if the TDP itself stops, the potential for it to trigger VFib is why identifying the cause is so vital.
Exactly right.
Yeah.
You have to find out why it happened.
Okay, let's talk causes then. What actually sets the stage for this?
We can broadly group them into two buckets. Congenital, so something you're born with and acquired, which develops due to other factors.
Congenital, like inherited syndromes.
Yes, things like Jervell-Lange Nielsen syndrome or Romano-Ward syndrome.
Yeah.
These involve genetic issues with ion channels.
And acquire, that sounds like a bigger category.
It is. And for the acquired causes, there's a helpful, if slightly clunky, mnemonic, CAT-MALE-SHIM.
CAT-MALE-SHIM. Okay, let's unpack that. What's the CAT?
Okay, C is for cardiac conditions. Think pre-existing long QT syndrome, obviously, but also things like acute MI or myocarditis. A is for acute kidney injury, and T is crucial toxins or drugs.
Ah, the medication link. That sounds important for exams.
Definitely. Many drugs can prolong the QT interval. Ironically, some antiarrhythmics can do it. Also, certain antipsychotics, some antibiotics like erythromycin.
Any others jump out?
Oh, yes.
Yeah.
Tricyclic antidepressants, chloroquine, even older antihistamines like terfenadine, though that's mostly withdrawn now.
Yeah.
It's a long list.
Wow, yeah. Okay, what about the rest? MALE-SHIM.
Right. M is for metabolic causes, hypothyroidism, significant malnutrition, anorexia nervosa.
Okay.
A is anomalies, mainly electrolyte imbalances. This is huge. Hypokalemia, low potassium, hypomagnesemia, low magnesium, and hypocalcemia, low calcium. Also severe hypothermia.
So checking electrolytes is key.
Absolutely critical. Then L is for liver failure. E for emergency situations like a subarachnoid hemorrhage.
Right.
S could be a sudden event like another acute MI.
Yeah.
H is hormonal. Again, hypothyroidism pops up. I is ionic, reinforcing those electrolyte imbalances.
Got it.
And the final M is just medications, again, really hammering home how important drugs are as a cause.
CAT-MALE-SHIM. That's a really useful framework. So moving down to the cellular level, what's physically going wrong in the heart cells?
It boils down to abnormal repolarization, that electrical reset we keep mentioning.
Okay.
The core problem is an imbalance, usually involving potassium currents. The flow of potassium ions in and out of the cells. Think potassium imbalance twist.
Potassium imbalance twist. I like that.
This imbalance messes up the timing, causing that delayed repolarization.
And that delay leads to?
It makes the heart muscle cells irritable, prone to firing off early abnormal beats. And it can also create conditions for what we call reentry circuits.
Like little short circuits?
Kind of. tiny loops of electrical activity that just keep going round and round chaotically. And it's these chaotic, varying circuits that generate that twisting pattern you see on the ECG.
Okay, that connects the dots nicely. So someone's having torsades. How might they actually present? What would you see or what would they feel?
Well, interestingly, maybe nothing. About half of the cases might be asymptomatic, detected incidentally on an ECG perhaps.
Half. Wow. So half silent, half scary.
That's a good way to put it, because for the other half, the symptoms can be quite dramatic. A very rapid, irregular heartbeat, palpitations, feeling dizzy or lightheaded.
Fainting.
Yes, syncope is common. And sadly, as we've mentioned, sometimes the very first presentation is sudden cardiac death, up to 10% in some series.
That's sobering. Any other symptoms?
You might get nausea, people can look pale, get cold sweats, shortness of breath, maybe even chest pain if it's prolonged or causing significant strain.
And history. Anything important to ask about?
Definitely. Ask about family history. Any unexplained sudden deaths, especially at a young age. Any congenital deafness in the family. That could point towards Jervell and Lange Nielsen.
Right, the congenital link.
Yeah.
What about physical exam findings?
It can vary. You might find a very rapid pulse during an episode. Blood pressure could be low or maybe normal between episodes. If they're having an episode when you see them, they might have a transient or even a prolonged loss of consciousness. Other signs will depend on the underlying cause, signs of heart failure, thyroid issues, etc.
Okay, so you suspect TDP based on symptoms or maybe an ECG strip. How do you confirm it and assess things further? What are the key steps?
Diagnosis really hinges on the ECG. That's where you see the characteristic polymorphic V-catch, the twisting, and usually that prolonged QT interval.
Right.
But immediately, you absolutely must check serum electrolytes. Potassium and magnesium are non-negotiable first steps.
Because they're such common triggers.
Exactly. Then, an echocardiogram is usually done to look at the heart structure and function. Is there underlying disease?
Makes sense.
And if you suspect a congenital cause, based on the history or very long QT, then genetic testing is something to consider. Think ECG KMG echo gene for your initial workup.
ECG, KMG, echo gene.
Got it.
Are there very specific ECG features we should be looking for beyond the general twist and long QT?
Yes, definitely. You often see it in short bursts or paroxysms, maybe 5 to 20 beats long.
Mm.
The heart rate during the TDP is typically very fast, over 200 beats per minute.
But it can be sustained.
It can be, yes, which is more dangerous. The defining feature is that progressive change in the QRS polarity, swinging from positive to negative and back again. That sort of 180-degree twist usually happens over about 10 or 12 beats.
Okay.
You'll almost always find a prolonged QT interval in the underlying rhythm, and sometimes prominent or pathological U waves.
Any specific numbers for the QT interval?
A QT interval of 0.60 seconds or more is highly suspicious.
Or
Using the corrected QT interval, the QTC typically, as that formula is used, a value of 0.45 seconds or more, is generally considered prolonged and a risk factor.
right.
And one other subtle but important clue, look at the beats just before the TDP kicks off. Often you'll see a specific pattern in the RR intervals, a short interval followed by a long one, then another short one immediately preceding the arrhythmia, the short, long, short sequence.
Short, long, short. Then the chaos starts. That's a good pearl. Any other tests needed generally?
Well, besides the electrolytes, checking cardiac enzymes like troponin is important to rule out an acute MI as the trigger. A chest X-ray and the echo help assess for structural heart disease. It's about looking at the whole picture, electrical, chemical, structural.
Okay, so we've confirmed TDP. It's happening or has just happened. What's the immediate management strategy?
You need to think fast and act fast. Two main goals. Stop the current episode and prevent it from happening again. Think, fix fast, long-term plan.
Fix fast first. What does that involve?
Immediately stop any potential offending drugs, anything known to prolong the QT. That's number one. And aggressively correct those electrolyte abnormalities. Give IV potassium if levels are low, and especially IV magnesium.
Magnesium is key, right? Even if the level isn't low.
Absolutely. 5E magnesium sulfate is often considered first-line treatment for TDP, regardless of the serum magnesium level. It seems to stabilize the cardiac membrane electrically.
Okay, magnesium first. What if it continues or degrades?
If it degenerates into ventricular fibrillation, then it's standard resuscitation protocols, CPR, and immediate defibrillation. That's obviously the most urgent scenario.
And for TDP itself, other than magnesium?
Increasing the heart rate can actually terminate TDP because it tends to shorten the QT interval.
How do you do that?
You can use drugs like isoprenolone, which is a beta agonist, to speed up the heart. The target is usually over 90 beats per minute. Or you can use overdrive pacing, putting in a temporary pacemaker wire and pacing the heart faster than its intrinsic rate.
So speeding the heart up can paradoxically calm the rhythm down in this case.
Exactly, especially for acquired TDP that's triggered by pauses or slow heart rates, which is common. Temporary pacing is quite effective for terminating episodes and preventing immediate recurrence.
Okay, that covers the fix fast. What about the long-term plan?
That really depends on why the TDP happened, congenital or acquired.
Right.
If it was clearly acquired, say, due to a specific drug or low potassium, and you've corrected that trigger, often no specific long-term antiarrhythmic therapy is needed once the QT interval normalizes. You just need to avoid that trigger in the future.
Makes sense. What if it's congenital LQT?
Then long-term management is crucial. Beta blockers are the mainstay. Typically, propranolol is first line. They help prevent TDP episodes in congenital cases.
But you mentioned avoiding beta blockers in acquired cases.
Yes, that's a key distinction. In acquired LQT, especially if it's related to bradycardia, beta blockers can slow the heart rate further and potentially worsen the situation, so they're generally avoided.
Okay, so beta blockers for congenital. What else for congenital LQT if beta blockers aren't enough or aren't tolerated?
For symptomatic patients who don't respond well, permanent pacing might be considered to prevent pauses. In very refractory cases, a surgical procedure called high left thoracic sympathectomy could be an option.
And defibrillators? ICDs?
Yes, implantable cardioverter defibrillators, ICDs, are used particularly for high-risk congenital LQT patients, like those who have survived a cardiac arrest or still have syncope despite beta blockers. They're often used alongside beta blockers, kind of as a safety net.
And back to acquired cases quickly, any long-term devices needed there?
Usually not, if the trigger is gone.
Mm.
But if there's underlying significant heart block or bradycardia that predispose them, they might need a permanent pacemaker. An ICD is rarely needed for acquired LQT unless the TDP proves unmanageable despite removing triggers, which is uncommon.
So what's the overall outlook, the prognosis for someone who's had Torsades?
It really varies. It depends heavily on the underlying cause, whether they have other heart problems or medical conditions, and crucially, how quickly it was recognized and treated.
Timely management is key.
Absolutely. Prompt action can stop it and prevent recurrence, but left unchecked, or if it progresses to VFib, it's clearly life-threatening. The long-term prognosis is tied to managing the underlying cause.
And is the prognosis different for acquired versus congenital?
Generally, yes. For acquired LQT, if you identify and remove the trigger, stop the drug, fix the electrolytes, the prognosis is usually excellent, the QT normalizes, and the risk goes away. For congenital LQT, it's more about lifelong management and risk reduction.
Prevention sounds important too.
Definitely. Avoiding QT prolonging drugs where possible, especially in patients with other risk factors. Managing electrolyte levels proactively. And for those with congenital LQT, family screening is really important to identify others at risk.
Okay. And finally, just to be crystal clear, what are the major complications we worry about with TDP?
The big three are the ventricular tachycardia itself, causing symptoms or hemodynamic compromise, degeneration into ventricular fibrillation, and ultimately sudden cardiac death.
Got it. VT, VF, and sudden death.
Those are the immediate dangers.
Okay, so to wrap up our deep dive on Torsades de Pointes, we've looked at that classic twisting ECG. It's linked to a prolonged QT interval. The diverse causes, remember CAT-MALE-SHIM for acquired ones, and how critical rapid diagnosis and management are.
Absolutely.
Yeah.
You have to address the reversible factors immediately, manage the acute rhythm, often with magnesium or by increasing the heart rate, and then plan long-term based on whether it's congenital or acquired.
Because the potential consequences, like VFib and sudden death, are just too severe to ignore. It's definitely a complex area, but hopefully breaking it down like this helps clarify those key features and steps.
It's certainly a high-yield topic, particularly for anyone facing exams.
Yeah.
Knowing the ECG signs, the main causes, especially drugs and electrolytes, and the acute management steps is crucial.
And for digging deeper or revising this topic?
Yeah, for anyone wanting more practice or revision materials, especially for the MSRA, check out resources like pastthemsra.com.
And I believe there's a free version too.
That's right. FreeMSRA.com also has useful resources. Definitely worth looking at.
Excellent. Well, thanks for joining us for this deep dive. We hope this has given you a clearer, more confident understanding of Torsades de Pointes. Until next time.